So let's get started. I am Dr. Lin. I'm one of the glaucoma specialists here. I'm also the Director of Medical Education here at the Gavin Herbert Eye Institute. Very happy to be doing this community talk. I would have wished that I can see everybody's face, but I know that if I were you, I would probably like to hiding anonymity and just enjoy dinner, have a little sip of red wine, and just listen on. But we will give you opportunity to type your questions, and we will try to address those questions at the very end. So I thought I would just talk about what I do on a day-to-day basis, as well as what my research is on, which is glaucoma. So it's hard to summarize glaucoma in a 30-minute span of time. So what I want to do is I compile a list of 10 top most frequently asked questions from patients, and in doing so, I wish I will be able to kind of give you a gentle introduction to what glaucoma is and what we can do about it. And in terms of disclosure, I'm a research consultant for J&J and NVIDIA, and I have research funding support from the American Glaucoma Society and the RPB. So here are the questions. So we'll start out talking about what is glaucoma and what causes glaucoma, how is glaucoma diagnosed, and what is considered quote unquote normal eye pressure, and how is glaucoma treated, and also a very commonly asked question, which is why is my vision worsening when my eye doctors keep saying everything looks okay? And then we'll get into whether there are supplements, diets, or exercises that may help with glaucoma. And the most dreaded questions, am I going to be blind? And then also we'll talk a little bit about people whose eye pressure has always been very low, and yet they were told that their glaucoma is progressing. So what's up with that? And finally, we'll wrap it up with what's coming down the research pipeline, some of the more recent developments and what is in the near horizon. So first, what is glaucoma? And here is actually pretty close to a textbook definition that you will find in any standard textbook. It is defined as a chronic condition in which the optic nerve loses its volume, and after it loses its volume, it's going to start to slowly lose its function. And it is most commonly because of this happens most commonly because of its inability to cope with the pressure within the eyeball. Now, the loss of the optic nerve volume eventually will lead to a loss of peripheral vision. And at that point, if nothing is still being done, eventually it's going to affect the central vision as well. So this is more of a classic sort of progression of events. In the beginning, most patients are not aware that they have glaucoma, and they start to lose peripheral vision, which most people are not aware of. And then eventually time goes on and family members starting to realize, why is Uncle Joe having to keep turning his head in order to see if somebody's sitting next to him or not, and finally realizing that Uncle Joe has no peripheral vision left. And finally, the last step, the last part of the vision to go away is the central vision. And hence, some people call glaucoma the silent killer because it does not give you any symptoms. In most forms of glaucoma, you do not have pain. In certain subtypes of glaucoma, you will have pain, but the vast majority of glaucoma patients do not have pain. And patients do not have any vision changes until the very late stage. Let's review the eye anatomy a little bit. What is optic nerve? Optic nerve, you can consider that as a cable that connects your eyeball and it sends the information towards the back of the brain. It connects to the eyeball and it acts as a conduit where all the sensors coming from the retina all converging to that point, about 1.5 million fibers, then go into that tunnel and then head straight to the brain. So it is a very important structure. It is basically where all the sensors just converge together. And in glaucoma, that optic nerve is susceptible to the pressure within the eye, and over time, when the pressure in the eye is a little elevated, it's starting to push onto the optic nerve, and the optic nerve starts to lose its volume. And once it loses about 30 to 40% of its volume, that's where peripheral vision starting to go away. This is what normal vision looks like. This is what patients with advanced glaucoma may experience their vision. Once again, it's important to know that straight ahead, you can still see what you're looking at, but what the patient may not be aware of is the loss of the side peripheral vision. So what I often do is I will tell a patient, this is very similar to losing about $20 a month on your bank account. Obviously, it depends on how much money you have in the bank account, but for the most part, if you lose $20 a month or even $10 a month, you're not going to be immediately aware that your bank account balance is going down. But after a while, that $10, $20 a month is going to start to accumulate, and it's going to start add up the effect. And then you may realize it down the road, but most people will not realize it right away that something is happening because you simply don't pay much attention, again, in this case, to your peripheral vision. So what causes glaucoma? The spotlight is really on the eye pressure because that is the only treatable cause of glaucoma. So let me say this again. Increase in the eye pressure is not the only cause of glaucoma. However, every therapy, every medication, laser, surgery, anything that we do is single-handedly focusing on reducing the eye pressure because that is the only variable that we can treat. We are starting to realize that there are pressure-independent causes that can cause glaucoma. And I won't get into too much of that because much of that is still in the realm of research. And also the sort of the big picture of that part of the research is that we currently still do not have anything that's FDA approved to treat these pressure-independent causes for glaucoma. So how exactly do we calculate eye pressure? It's essentially a plumbing problem. So eye pressure, just think of that as how much fluid is being produced in the eye minus how much fluid is exiting the eye. If there is an imbalance in how much is being produced and how much is being drained away, then you're going to have a pressure problem. Just think of input, output. If you eat too much and you're not putting out as much, you're going to start gaining weight. And in the case of an eye, the pressure is going to start going up. The opposite situation, if you're not putting in enough and yet you're draining away a lot, obviously the pressure is going to go down. For literally 99% of glaucoma, the problem is not at the production of the fluid part. The problem is all happening at where the fluid is exiting the eye. In fact, almost everybody with glaucoma, the problem is at the drainage side, the internal drain that drains away the fluid in the eye. Now, this drain is not the same thing as what drains your tear. Your tears are external to the eyeball. What we're talking about here is the fluid that's within your eye, something that we call the aqueous fluid. And that's completely separated from the outside part of the eye, and it has its own internal system. So if you look at the picture here on the bottom right corner, the wavy yellow arrow indicates the path where the aqueous fluid travels within the eye. It comes from sort of the right next to the lens that you see there, and then it is produced in this little tissue called the ciliary body. The fluid gets produced here, and eventually it leaves the eye in the front chamber, what we call the anterior chamber of the eye, which is formed between the cornea and your iris. And the aqueous fluid will exit here through the drainage angle. So people with glaucoma, they're not producing too much fluid. The problem they have is they're not draining enough at where the drainage angle is. So either their drainage pipes are not big enough, or the drainage pipes have a lot of obstructions. So why is that? So what causes glaucoma? For basically most forms of glaucoma, the problem comes down to the size, density, and porosity of the drainage system. And you don't really have much control in terms of the size and the density and the diameter of these internal drains. In fact, that is the reason why glaucoma is highly hereditary, because just like your height and your weight and your body features, a large degree of all these features are passed on through and written in your genetic code. So the fact that genetics plays a big role in glaucoma, you can interpret that from the angle of that's what determines the size and density and basically the physical feature of your plumbing system inside of the eye. And I highlight the word genetics in red. That's because that is really the majority of the causes at the molecular level. That's what's happening. All the other items on this list here, they can sometimes cause glaucoma, but they're more on the rare side. Of course, in our university clinic, we do see a lot of causes of glaucoma from all these other items here, but they're not, if you have to take a guess, it's usually not one of these. So let's go over some of these lists here. Pigments in the eyes. There is a type of glaucoma called pigmentary glaucoma, in which the eyes, inside of the eye, there continue to be shedding of the pigments that reside in the back part of the iris. And this type of glaucoma, there is a very strong family history as well. And these pigments get released and they don't have anywhere else to go but go to the drain and start clogging up the drain and causing pressure problem. Trauma is a very important cause. If you play baseball as a kid and got hit with a baseball towards the eye, that can certainly damage those internal drainage systems that I showed you earlier. Being on steroid is notorious for raising the eye pressure, and especially nasal spray. So that's something that I always ask my patients, are you on steroid? Were you on steroid? Eye surgery, that is also a very big category. Any eye surgery that takes place inside of the eyeball, including cataract surgery, or even just on the surface of the eyeball, can all have the potential to cause glaucoma. Just think of your house. If you have an electrician coming to fix certain things, can the plumbing system be affected? Absolutely. And your eye is a very small space. It is hard to be fixing one thing without affecting other parts of the eye. And that is kind of a 30,000 feet view of why doing eye surgery sometimes can then lead to pressure issues. Uncontrolled diabetes is another very common cause, and also very low blood pressure can also cause a glaucoma-like picture. So how is glaucoma diagnosed? Well, again, we focus a lot on the eye pressure because, again, that is the only thing that we can treat. So we need to find out what the eye pressure is. And we also need to do a comprehensive eye exam, looking from the front to the back part of the eye, looking for any other obvious reason for the pressure to go up. And some of these reasons could be that there is unusual anatomy, or there may be a little mass or lesion or tumor obstructing where the drainage system is, things of those nature, trying to identify things that may explain why the pressure is up. And also we'll take a look at the anatomy of the optic nerve, how the optic nerves look, how thick is the optic nerve, and then we also do a functional test, which is what the peripheral vision test is. The gold standard for checking the eye pressure is through what's called an applanation tip, which is the picture that I showed here on the right bottom here. It involves touching the eyeball. This is the most accurate way of checking the eye pressure. I'm sure you're all aware that there are other ways to check the eye pressure, including an air puff or tonal pen, or even there are now home eye care kits available for you to kind of check on your own eye pressure. None of that has been shown to be as accurate as the applanation tip. So here is an example of a peripheral vision test. Many of you may have seen this before. We had to put your head in there and different light dots will go on. You're supposed to look straight ahead. It will not be much of a peripheral vision test if you cannot look straight ahead and you just keep chasing after the dots. So this test is meant to see how to really get down to the grainy details of how good your peripheral vision is. And it puts out a picture to represent how your peripheral vision looks. And this is pretty much what we consider as a normal peripheral vision. There is a little blind spot, a little dark spot that you see there. That's a physiologic blind spot. Everybody should have that. The other test that we administer to the patient is the optic nerve scan. This is basically a way using a laser technology to quantify how thick the actual optic nerve is. It's not enough for us to just look at it head on. We wouldn't be able to tell to the micron level how thick the nerve is. And this machine here allows us to analyze what the average thickness of the optic nerve is, and pictorial, and it shows it in picture, and it can also track whether your optic nerve is getting thinner and thinner over time. So we're not so much comparing any patient against all the other patients. We're very much in when we say glaucoma follow-up, we're following up how that particular patient's optic nerve is looking over time. So we're just comparing you with you. We're not really comparing you with everyone else. So that leads me to the next question, which is, what is the normal eye pressure? So there is, experts don't even have a consensus on what exactly defines the eye pressure, because the question itself is actually not a very scientific one, because there is no such thing as what's the normal eye pressure. Just like heights, there is no such thing as a normal height. When it gets too short or too tall, then we start to get a sense of, oh, that's not kind of normal. But there is a lot of subjectivity to it, and the eye pressure really varies widely. And the problem with trying to define a normal eye pressure that works for everyone is that we really don't know how much pressure each individual eye can take. For example, your right eye may be able to soak up a different amount of pressure compared to your left eye. And by looking into the eye, we're not going to be able to identify a sentence that says this particular eyeball can only tolerate a pressure up to X. I mean, if that's how we were made, then that will make our job very easy. Unfortunately, when I look into your eye, I cannot identify a line like that. So we had to figure out what is a good pressure for this eye. So again, that goes into the next item here, which is it is unknown how susceptible each optic nerve is to the effect of pressure. The population range for the eye pressure is between 7 and 22. So we know that this range essentially encompasses about 98% of the population spread of the pressure, with an average of 18 and a standard deviation of 3. You may have gone to eye doctors in the past, and the doctors will basically say your pressure needs to be 21 or under, which is it's a concept that has been proven a little obsolete since about early 2000s. The reason that 21 kind of comes about is the average plus one standard deviation of 3. So 18 plus 3, that's 21. So it used to be that this 21, the number 21, was used to conveniently define what is normal versus what is abnormal. Unfortunately, reality is not as simple as that. Just like Newtonian mechanics cannot fully define how the physical world interacts, and then we need a quantum mechanics. Everything is just reality often turns out to be a little more complicated. So we've learned that if we just arbitrarily set 21 as the target, we're going to be overdiagnosing about 30% of the people and miss out about 50% of the people. So this 21 threshold really does not apply. And the reason why it doesn't apply is every eyeball simply tolerates different amount of pressure. So we cannot cast a wide net and say just use 21. Otherwise, you probably don't even need to see your doctor. We can just set up stands where you can just get your pressure checked. So that's really not the case. Instead, glaucoma specialists use what's called a target IOP. IOP stands for intraocular pressure. And in many cases, it takes many months of observation to really test, to define a target IOP, because you simply don't know if this person is going to be doing fine in this particular pressure, unless you let that person kind of run in that particular pressure for a while and see if the nerve continues to thin out. And that really is the forefront of what the field is heading towards. It's more an individualized treatment goal, rather than just say, okay, let's just get your pressure under 18 or under 15. We kind of need to look at where your pressure has been and where you are right now and how your testing is looking, and together kind of come up with a number. And target pressure can be different between the two eyes. So how is glaucoma treated? We almost always start out with medications, medication eye drops, and there are generally up to about 4 different types of eye drops. And I say types. The types refer to how they work, their pharmacologic targets. Most of them will make your eye to produce less fluid. So remember what I said earlier, eye pressure is basically how much fluid is being produced minus how much is being drained out. So if you reduce the amount of production, then you can lower the pressure that way. And that's actually how most of the eye drops works. There are a couple of new glaucoma medications that were recently approved by the FDA that work through an entirely different mechanism. It inhibits a very interesting protein target called the Rho kinase. Now that is a very new medication. Some of you may have heard of that. So that we're very excited to have that medication added to our typical armamentarium to treat glaucoma. But generally, we start out with medication. And if these medications are not enough to lower the pressure, then we consider additional steps, such as laser or surgery. Now, the one thing that's important to keep in mind about doing these eye drop, medication eye drop, is that they will not help you to improve your vision. Your optic nerve is as old as you have been. Generally speaking, they also age too. So what these eye drops are doing is trying to slow down that deterioration process. So just say, no matter how you remodel your house, you're not going to make your house brand new unless you just tear them down and build a new one. But since we cannot just take out your optic nerve and then swap in with a new one, what we're trying to do here is trying to preserve its function as much as possible. So when you are operating under a preservation mode, by default, you simply cannot exceed where you are right now. And our goal is always to try to maintain the optic nerve function as its status quo. So I always tell my patient, no news is good news. And the next is laser. Laser is a very commonly, it's a very safe option to try to lower the pressure as well. And then there's surgeries. Cataract surgery oftentimes can also lower the pressure. And then there are several procedures that are lumped into what's called minimally invasive glaucoma surgeries. And finally, there are the traditional glaucoma surgeries, which include trabeculectomy and glaucoma tube shunts. The higher the risk of the surgery, the greater the return and the reduction of the pressure. So it works kind of just like investments. The lower the risk, lower the return. The higher the risk, the higher the return. And the same thing can be said about glaucoma surgeries. The safer the surgery, generally, the less pressure reduction you tend to see. The higher the risk, you may potentially see a large drop of the eye pressure. Here is just some pictures showing trabeculectomy. Trabeculectomy is essentially where we create an opening on the wall of the eye to let the fluid drains out. And then we covered it up so the fluid will not just keep leaking out and you will feel like you're tearing. It's not that. We just make the opening such that the fluid will directly go towards the back of the eye. So everything is still covered by the top layer of the eye called the conjunctiva. Another traditional surgery is called the glaucoma implants, where we actually put a hardware right above the walls of the eye with a tube that then eventually we direct it into the eye to help drain the fluid. And this hardware will help direct the fluid towards the back of the eye. I do this procedures a lot. It's called trabectome. Trabectome is one of those minimally invasive glaucoma surgery that we often do at the same time as cataract surgery. What it does is, you can see in the picture here on the right bottom corner here, we place a trabectome instrument tip into the eye, and it simply removes the top layer of the drain. And in a sense, you can think of that as just cleaning the drainage system by getting rid of all the junks and all the gunks that have accumulated there over the years. So it removes that, use electrocautery, and also suction it out using an irrigation aspiration port. There are also eye stents. Many of you may have eye stents placed at the same time as your cataract surgery. That is also another way to trying to get through that drains by putting a tiny little stent. In fact, the stent is the smallest FDA-approved foreign body that exists. It is so tiny that if you put it on your finger, you probably can't even see where it is. And it goes into the drainage system and helps to keep it open. So the next question is, everything seems fine, but vision is declining. Why is that? So Again, this goes back to the point that I was making earlier. Glaucoma rarely causes noticeable vision changes. So when patients come in and they keep noticing vision is getting worse, we first need to make sure that everything else is looking fine, because very often it is not a glaucoma that's doing the vision deterioration. It is things like dry eyes, retinal problem, corneal problems. Those oftentimes will affect your central vision, meaning your vision that's straight ahead. Glaucoma, again, affects your side vision. So it is rare that it will affect what you see straight ahead, unless it is very severe and at the very end stage of it. And also, we need to realize that vision decline can occur simply from an aging eye. And I think I kind of talked about this point earlier, that the plumbing system in the eyes, they're basically as old as you are, and they don't degenerate. And so the interventions are meant to slow down their decline and not to restore their function. This plot here is actually from a paper published from UCLA about 5-6 years ago. It shows that on the top here, you see the slow progressor. That basically refers to people who don't really have glaucoma. And you can see from birth to death, even if you don't have glaucoma, your visual function will decline. Now, if you have glaucoma, you decline much faster. You're one of these solid lines. You can drop down a lot faster if nothing is being done. Or if we intervene early, then we can try to slow down the decline of the visual function. So that's really a key point to understand. Yes, the vision may decline, but if you don't have any treatments, if you're not on the eye drops, you may decline even faster. So what about supplements? There is no direct effects from any diet, supplements, nutraceuticals in preventing glaucoma progression or preventing glaucoma from happening. However, there was a very recent publication in a very reputable journal about 2 years ago, shows that meditation and positive mindsets have almost the same effect in lowering the eye pressure as one single class of medication. So I always tell patients, healthy mind, healthy living leads to a happier brain and healthier cardiovascular system, which always helps, because if you have healthy vessels, the blood vessels goes everywhere, including your optic nerve, including your eyes. They will then bring nutrients to your optic nerves and make sure that they stay very well nourished. So just healthy living, positive thinking, that's something that's still within your control, and that's something that you can certainly optimize. So while there is no direct link between any of the supplements and glaucoma progression, I do firmly believe that if you live healthy, eat healthy, exercise, that at least you're optimizing the variables that are still somewhat within your control. Am I going to be blind? I get asked that question a lot. I would say most likely no, but theoretically, yes, that's possible. So there have been ample of studies looking into exactly what is the rate of people going blind. So the most recent statistics is that it is very low, somewhere a little less than 0.1%. And just to put things in perspective, the odds of you dying in a vehicle crash, that's actually 0.97%. So almost 9 times higher. You're 9 times more likely going to die in a motor vehicle accident than you go blind from the glaucoma. And I believe that rate for going blind is going to continue to get lower as we improve on medical and surgical treatments. So the simple answer is no. Especially if you do your medications, have your regular follow-ups, the chance of that happening is almost just statistically non-significant. So what happened to, some people may ask, what about those 0.1% people that still go blind? Well, that gets back to the point I was making earlier. Eye pressure is not the only cause of glaucoma. So while we can take care of the pressure part, we simply don't have any effective means of taking care of non-pressure related causes. And also, some people actually lose their sight from glaucoma surgeries, which, as we know, it carries a significant risk trying to tinker the pressure system in the eye. So people do have can develop problem from surgeries. And also, some people just have late diagnosis. They get diagnosed very late. The nerve is already very damaged and very susceptible to even to just be barely alive type of a picture. So that certainly is possible. However, it's important to keep in mind that while very low percentage of people eventually go blind, 10% of the patients with glaucoma will have some degree of vision impairment. And that's usually some degree of peripheral vision loss. Sometimes the peripheral vision loss is so obvious that the patients are aware of it and they need to start turning their head and look around. And that can be an issue, especially when it comes to driving or walking on the street. You don't see what's in front of you, for example, or on the ground, you don't see a little stones or something in front of you. You can trip and you can fall. Now, question number 9, can glaucoma worsen even with a very well-controlled eye pressure? Again, yes, very rarely. For a reason I mentioned several times, there are pressure-independent causes. And then also, some other conditions in the eye can also mimic glaucoma, such as a small stroke affecting the blood vessels supplying the optic nerve. Migraine sometimes can mimic that too. And also, experiments suggest that optic nerve function can continue to deteriorate even after we reverse and normalize the pressure. I tend to think of that as, once the water pipe is broken, the water is out. Even if you fix the pipe, the water is still out. You still have to deal with the mess that's out there. So fixing the pipe is one thing. You don't really just stop the damage there. There's all the water that's coming out. So that's just one analogy that I often use. But that doesn't mean that we shouldn't do anything, because if we don't do anything, then the consequence is even worse. So that doing something, meaning fixing the pipe. And in glaucoma, at least we should lower the pressure. It doesn't mean that the damage will just stop right there, but the damage will always be worse if we don't do anything about it. Now, final question, what's coming up in the horizon? Well, I kind of make this list in terms of sort of chronological order. I think the next wave that's coming in is the sustained drug delivery. Intraocular, which there is currently one already just very recently approved by the FDA. It involves injection of an implant that slowly releases medication into the eye, so you don't have to be doing the eye drops. And also contact lens-based delivery of the drug, or punctal plugs. So these are ways to kind of reduce the inconvenience of putting drops on your eye every day. And new classes of glaucoma medications may emerge with entirely different pharmacological targets. That's always in the work. Also, objective field analyzer. Many of you who have glaucoma here are listening. You probably, I can guess that you don't like taking the peripheral vision test. I'm totally with you on that. Peripheral vision test it's challenging. You never feel like if you're hitting the right answer, if you're being consistent or not, and you sit there and you stare at straight ahead, most patients can fall asleep or just feeling frustrated. So objective field analyzer is something that is going to be very revolutionary. You just look into a little goggle-like device. You don't need to click any buttons. It uses your pupil response as a way to test your visual function. So we're actually very excited to be, I'm going to be one of the principal investigators on the clinical trial testing the objective field analyzer. We were originally going to start that clinical trial enrollment this year, but because of the COVID, the company that's making the analyzer has some supplier issues. So that may not happen until sometime next year. So stay tuned. And of course, artificial intelligence with machine and deep learning, that's always making a major impact on many corners of medicine. My laboratory group is working on that too. High resolution live imaging of the drainage system to help guide and target glaucoma surgery. That's also another interest in my laboratory. And also smarter glaucoma implants that are very small and that can regulate pressure by itself. That's also coming up in the horizon. And finally, stem cells and optic nerve regeneration. Although I think we're at least several years away from that. That's a very complicated challenge to solve, with many sort of smaller challenges that need to be overcome first. All right, I know I kind of run a little over time, but thank you very much for your attention, and I'll take a look at your questions and answer them after Dr. Wade's talk.